Several questions, and again, we'll try to get to as many as we can here now. Some will fit potentially even better in the breakouts or later in the day, but we'll get to as many as we can. One question is somebody who presents with, within the first few days, not with an immediate sense of things are better, but new pain, new lump, something like that. Is there any way to get a quick sense of whether this might be pseudo-progression, inflammatory response, or just plain rapid progression through the treatment? In other words, any sense of how to decide when to continue to follow or when to cut your losses and move on quickly? I'd ask both of you.
Sure. So it's not uncommon in the first week or two after treatment for patients to say their tumors hurt more or they feel a little bigger. And that's unusual for the behavior of the tumor to change so quickly in response to the therapy. So we usually feel that that's likely something going on in the tumor. And if you think about the cartoons that I presented, the immune cells have to be in the tumor, they have to grow, they have to do things. Theoretically, that could be painful. So early on, we tend to just say, let's wait and see what happens. And oftentimes, those type of symptoms get better. Now, if we're 6 weeks or 10 weeks into treatment and the patient's tumors are getting better and the patient is not just the tumors are getting bigger, but the patient is feeling worse, then we worry. And we might do a CAT scan earlier in that setting. We might look at markers, if there are markers of tumor, such as LDH and melanoma, see if that's getting better or worse. But not everybody responds, and so at some point, it might have to switch to another therapy. If the patient, as Jason Luke said, if the patient is feeling better, but the tumors are feeling okay, but the tumors are growing, we often wait for the CAT scans and may even wait beyond the 12-week time point for another set of CAT scans before we say that this isn't going to work. And sometimes, even though tumors are growing, they might actually start to shrink later on.
Other comments?
I think that's what we've seen also in our population, and part of it depends on how severe those side effects are or those symptoms they have, how short of breath they are. Is there a tumor perhaps that's right next to a major airway and is going to be really compromising their respiratory status that you might need to intercede more quickly? And we've had some cases where after the first therapy there was that flare effect, and some patients have maybe even needed a little break in treatment and needed radiation intervention to help relieve some of those symptoms, and then went on to continue receiving the therapy. So it really is going to be depending on the patient, how severe, how much they can tolerate that flare effect and those symptoms. So it's going to be on a case-by-case basis.
What about, one person asked about using Remicade or Infliximab. Is that a therapy, an intervention that has been pursued to abrogate potential immune-related toxicities? Is that needed? If so, when do you pull the trigger on that? I don't know if you've ever used it.
I've had less experience with it in the lung population. We've seen it more so with the patients in the earlier trials with the ipilimumab or CTLA-4 treatment, and only if they didn't respond to steroids, methylprednisolone.
Right, so I've had a lot of experience giving ipilimumab, and about 20% of patients may get diarrhea or colitis, and if you give high-dose steroids and the diarrhea and colitis doesn't get better within 3 to 7 days, depending on how severe it is, or it gets better, but when you're tapering the dose, it gets worse again, that's usually a situation where we will switch to Remicade, which is an immunosuppressive antibody, and which has been typically used to treat ulcerative colitis. And often just one dose of that will very quickly control the colitis symptoms. And then we can taper the patient off of steroids, and usually the colitis won't recur. Occasionally, we might need a second dose, but this is not like the ulcerative colitis that presents in the absence of immune therapy. Once the ipilimumab is out of the system and the colitis is better, it's not going to recur, so you don't have to keep giving it.
Several questions came in, thank you, by the way. Several questions about steroids in the patients who need them. In the lung cancer community, we've seen for about a decade some data, at least at a population level, that the toxicity of the EGFR inhibitors, mainly causing rash, may be correlated with a better response, although that it's not a perfect correlation. And some people are very happy to have that, or fearful if they don't have a bad rash that they aren't going to benefit from these agents. Is there a concern, and should there be a concern, about initiating steroids or other interventions to abrogate toxicities that you're going to significantly curtail the beneficial effects of these agents? Is there any correlation of development of some of the immune toxicities with more pronounced benefit in these populations? I'll start with you, Dr. Atkins.
Sure. So in our early experience with immune therapy, we were loath to give steroids. So in the interferon and IL-2 days, we avoided steroids at all costs because they shut off the immune system. And I think that some of the early experience with toxicities with ipilimumab were because people carried into the treatment that bias and were waiting and hoping the side effects would get better before they started steroids. But we've come to be much more aggressive about starting steroids. I think I tell my patients that every day you wait is probably an extra week it's going to take for the toxicity to get better. And we feel that way because experience with ipilimumab is that the stimulation of the immune system, once it happens, is powerful enough to keep going against the cancer, even in the setting of steroids, even in the setting of giving Infliximab or Remicade. And so I think we're finding ourselves treating the immune-related adverse events earlier. And we're seeing that many of our best responses are in patients who didn't get a lot of therapy but had those toxicities. So I'm telling patients who are worried that they're only getting 2 doses of ipilimumab or their treatment is stopping early because they're getting steroids that they've reached the end point. The end point is to induce an immune reaction against your tumor. If we can do it against your colon, then we've probably done it against your tumor as well, if it was possible to do it.
Question for Rusty. Actually, a couple. One will be, can you discuss any side effects you experienced directly other than rapid loss of opportunities to biopsy cancer? And also, are there, you had mentioned the kind of serendipitous path that led you to Memorial and the trial. Do you use any online resources, discussion groups, or anything like that, or do you think that is a potential tool to also get the word out to other people?
First of all, on the side effects question, with nivolumab, it's been almost non-existent. But prior, when I did the IPI, it was just incredible fatigue and muscle pain, joints, very lethargic. I actually was on steroids prior to that, and of course had to wait and taper off before I started on IPI, and I had a recurrence after the third treatment, but I did finish. I went ahead and had the fourth. The online, the melanoma world, it actually has some really good support groups. They're recent. 8 years ago when I was diagnosed, I used the internet for evil instead of good because, it's something that you should not do. for a variety of reasons. One, false information, and the other one is treatments that you probably don't need to try, like habanero peppers and garlic for breakfast.
Mm-hmm. Well, it's interesting. I think that's one of the challenges of we see all sorts of different responses. Some physicians say just don't look online, you'll only find misinformation, and of course there is some misinformation. The internet's an easy place to perpetuate both good and not so good information, which is part of why GRACE and MRA and others are really committed to trying to push out good information to make that credible content available to people. What about a question for Dr. Atkins? Is there any evidence that radiation or any other kind of priming event, whether it's some kind of adjuvant therapy in the sense of helper or immunostimulation, can enhance the immune activity with these agents?
Sure. There's some anecdotal evidence, and it's an area of active research. I think the question comes down to, can you induce an immune response in a tumor where there isn't one,
right,
by giving a vaccine or by giving radiation or by injecting something into the tumor, such as an oncolytic virus? And there's some suggestion that that might happen, but also there's this data that suggests that what the immune system recognizes are these neoantigens that come from these mutations in the tumor, and therefore those are already there to some extent, and the immune system may already have been exposed to them when the tumor's been there for many years before it's actually detected. So it remains an area of research to know whether you can induce an immune response that didn't exist, or whether all the tumors that are going to be responsive to immune therapy have already auto-vaccinated, essentially.
Is there much evidence of different subhistologies of the various cancer being far more immunoresponsive than others, whether it's squamous versus adeno lung, or the different subtypes of renal cell or some other setting?
Well, that's a great question, too. I think there's some, certainly, data in melanoma that uveal melanoma or potentially some other subsites of melanoma may not be as responsive. We've looked at tumors that are BRAF wild type versus BRAF mutant versus NRAS mutant. We haven't really been able to tease that out. In lung cancer, I showed a little data about smoking-related cancers potentially having more PD-L1 expression and being more responsive than EGFR-related cancers or cancers in non-smokers. So we think we'll be able to tease this out a little bit, and hopefully some of the factors that I was talking about will be able to tell us ahead of time which type of subtypes are the ones that are more likely to be responsive than not.
Several people have asked about next generation or genomic sequencing, getting those data. Is there any role for any markers that have yet yielded any promising strands of predictivity for benefit or away from that? Or is this still, are we still babes in the woods at this point?
We don't know for sure, but that's probably not the way the immune system works, that we're going to identify particular markers through next generation sequencing that are associated with benefit, but it's an open question. One place where we're using next generation sequencing is to just get a sense of mutational load, and then try to correlate whether that mutational load in a group of patients who've been treated helps predict for who's going to respond or not. But that's not looking for a particular mutation, that's looking for a frequency of mutations.
Right, so just this concept of mutational load being that some cancers have a greater burden of just a number of mutations, and there being a correlation between that raw number of mutations or mutational load and the immunoresponsiveness of that cancer subtype or maybe a particular cancer, but we're still learning about that. Coming back to toxicity management, we are at a point of inflection now where these therapies are rolling out from primarily the centers that have done the research and developed a lot of experience with it to broad utility in centers where there is not as much experience. And several of you mentioned, and it was alluded to before this as well, that it's really helpful to identify toxicities and manage that proactively. Is that a real concern about the ability to translate this into a broader setting? And how are some of the ways that you're talking with various companies about safely integrating this into community practice where people might see 20 or more patients in a day and not have that experience? Is there any potential to have some hotlines to call for around the clock, not necessarily individualized advice, but at least guidance about when to contact their doctor, or quick fix kind of things to think about? I don't know if you've been troubleshooting or thinking about the possibilities as this rolls out broadly.
So a few different answers to that. One came from our experience with the anti-CTLA-4 experience in Yervoy, and when we were looking at how we educate the general public when this was going to be approved, was to develop patient education materials, patient education cards that patients can carry around, so that if you were in a motor vehicle accident, if you had to go to another physician or go to an emergency room, it really outlined the steps that you were on in immunotherapy and exactly what should be avoided or what should be referred to your general oncologist that was treating you. A lot of educational sessions. I know as a tertiary center, we're now rolling out some of our trials to our community offices. And it's just a lot of education to the nursing staff, those that are even doing telephone triage in offices, to understand when to pick up those subtle side effects that patients are reporting in and when to refer that to the healthcare provider. And then the key is really educating patients from the very beginning that they've got to really be empowered to understand what those potential side effects are and stress those with any other healthcare provider that you might see, so that you don't perhaps start another medication that might interfere with the therapy that you're getting, and that it comes back to the treating physician. So I think empowering patients through these wonderful websites, too, to put the appropriate and accurate information out is helpful. Having the pharmaceutical companies really support patients with providing educational materials is helpful as well. And some facilities do have hotlines. I know on the Yervoy card, they actually have a hotline that patients can call and other healthcare providers can call if you were to carry that. And other pharmaceutical companies are following suit as well, so that in case you didn't have resources at your remote areas, that they could call in 24-hour hotlines to really triage and manage symptoms that might occur.
Well, the fact is that a lot of the patients who are seeing all of you are coming from a distance, passing other healthcare facilities, and if there's some urgent thing like becoming short of breath, potentially landing in a local hospital, as you mentioned, Dr. Atkins, that time is very relevant in terms of starting the most appropriate therapy. And I believe you and I were in a session a week ago where I think it was there, someone was relaying a story, and it might have been you, about somebody who had a delay and was in the ICU setting, and a very late introduction of steroid therapy that ended up translating to a much longer ICU stay than might have been the case had it been recognized that the patient was on immunotherapy and that steroid therapy would have been a very appropriate consideration. So it's really, I think, important for us to try a multi-pronged approach. I mean, having some broader resources no matter where you are, educating patients, having materials online, and as well as trying to educate, of course, the docs everywhere about this.
I was given a card very early on with the drug, an 800 number, as well as a doctor's name that they can, and it was used a couple times.
Okay.
With local.
And you didn't even have well, actually, that was with Yervoy, you said, so was that the agent? Or?
It was with both.
Okay.
So my concept, which has never really caught on that I wanted BMS to do, was to have a toilet paper that was labeled with numbers to call.
It's weird. Yeah, you've got it might have been the marketing people who got involved. I don't know. All right. Well, thank you all. As Wendy said, the lunches will be outside, and please join the most relevant breakout group for you. We'll reconvene here at 1:20, I think, or at 1:30. A little break after that. So thank you all.